Hello, everyone, and welcome to this live stream session on increasing compassion, decreasing barriers for pregnant or parenting people. We have 3 great presentations today, and we'll try and get here on time, so with these rapid-fire sessions. Up first, we have Pamela Joshi, and she'll be presenting on the Blueprint for Perinatal Substance Use Continuum of Care in British Columbia. Thank you, Pamela.
Thank you, everyone, and thank you so much for this opportunity. Yep.
Sorry about that.
That's okay. I can talk about VBR, but it won't be very good. I can tell you right now. I'm going to leave it to our experts here today. So my name is Pamela Joshi. I'm Program Director of the Provincial Perinatal Substance Use Program at BC Women's Hospital. I have the privilege of doing strategic work and directing this provincial program that's really focused on improving care for pregnant and parenting women using substances. And also, just really looking at system transformation in this area. We know that this group of people and life givers experience the most stigma of any substance using population. And this work is really developed and designed to help support, greater understandings and more concentrated effort to support pregnant people on this journey in recovery, whether it's abstinence-based or whether it is active use-based. So I have many things to declare, so I have no conflicts of interest and I have no disclosures. I want to acknowledge our funders. It's on the 3rd slide now, I think, of the BC Ministry of Health and BC Ministry of Mental Health and Addictions, without which this work would not be possible. They are our generous funders, and I'm not using the clicker, so that's why this is not happening very well. Oh, perfect. The most important acknowledgement I'll make today is our land acknowledgement that at BC Women's we are grateful to be working on the unceded traditional ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations of what is colonially known as Metro Vancouver, and we also acknowledge all First Nations, Inuit, and Métis status and non-status identities. We have the privilege to serve in this work. Along with the land acknowledgement, I would be remiss if I didn't acknowledge the work of Dr. Elder Roberta Price and Elder Glyda Morgan, who are Indigenous elders who are part of this team, and the presence and work of Carly Stewart, who is of Mohawk, Oka, and Cree ancestry, and a person with lived and living experience on this team. So today I hope to share with you that the blueprint was not something developed quietly in a back room. It was very much the culmination of our learning over 3 years across the province in our collaborations, really figuring out what actions, what leading practices, what evidence exists in the perinatal substance use field, and pulling it all together in one place and space so people can access it. So a little bit about the program. We started about 3 years ago. Really the genesis story was from a workshop with 90 people getting together to talk about ensuring best care for pregnant and parenting people using opioids. And from there, with that group of 90 stakeholders, it grew and grew and grew every single year till now we're at the point of having 300 stakeholders and champions engaged in this work. And for us, that's just a tremendous growth because we started with 90 people really kind of talking about this major issue and then having it expand and grow over time. Really, at BC Women's, we have the role of centralized provincial leadership of this work, and we do that by working really collaboratively across the province with community and regional health authorities to determine what education initiatives, what clinical practice initiatives, what cultural safety initiatives we need to take on to support advancing this continuum of care. This colorful wheel that I'm sharing here is really about our guiding principles. And what we mean to impart by this is that doing this work with pregnant and parenting people and life givers using substances requires a lot of principles and practice. And it's about, trauma and violence informed care and Indigenous cultural safety really in the foreground. But there's so much more around this about evidence-based equity, working in an interdisciplinary way, putting mother-baby togetherness at the forefront. So this is really where our guiding principles are really foundational for all of the work we do. It's the bedrock of our work. And one thing I will say is that we also have such significant community partnerships across BC in this work, and I'll talk about that in brief and what that means to us. And notably, these are direct service, direct care partnerships. So our program approach, we have a small team. We've got about 7 people working on this, and it includes clinical education leadership, as I said, people with lived experience, our elders, and evaluation specialization, administrative and program coordination, and myself at the moment. We also have a physician consultant medical director, Dr. Annabelle Mead, who's been a champion in perinatal substance use and women's substance use for many, many years. We have 5 regional working groups connected to this program, and I see one of our regional group co-leads here today from the north, and I hope you can give a little wave because the work in the north is outstanding. And the other remaining regions have 4 executive co-leads working on really talking about local, regional, and community action within the region to catalyze perinatal substance use work. The thing that I really wanted to talk about was that we have so many layered initiatives, and that's really foundational to this blueprint. So along the way, we knew that there was a huge need for education in this area, a huge need for Indigenous cultural safety approaches and approaches to decolonizing perinatal substance use. And we also knew that there's a lot that needs to happen in clinical practice initiatives to do this work. So it's really, that's an area I'll be talking about a lot today. So on our Indigenous cultural safety journey, this I think would be the most important work that we do in perinatal substance use. So this is about decolonizing perinatal substance use care, and this can only be done by taking action. So some of the actions that we've taken include engaging elders as a part of our team, providing support for an elder in residence program at FIR, the BC Women's 12-bed unit for stabilizing women who are pregnant and parenting and using substances. This involves really aligning our work to all of the policy directives and the initiatives like In Plain Sight, the report on missing and murdered Indigenous women, Sacred and Strong, honoring Indigenous women's pregnancy journeys, and really understanding that gender colonial violence against Indigenous women and life givers in particular is strong. It's been perpetuated over time. It continues. And unless we take approaches that really honor and support the reclamation of birth work by Indigenous people, by elders, by leaders, by doulas, by midwives, we cannot support stronger maternal health. So we know that Indigenous women's health is everyone's health, and that's very strong in all of the work that we do and the teachings of the elders that we work with. So I really want to impart and stress the importance of this work. One thing that we did as a part of the provincial program is that we convened 10 elders across the province, all working in perinatal health, maternal health, and substance use and harm reduction. And we got them together and we said, what are your teachings in this area? What do you want people to know? And we put it all together in Elders Visioning Toolkit that can be accessed by anyone in the province to help bring elders into healthcare. So it's just, this is the lens that we do this work from, and we really hold this work up with the highest honor and respect. I think the last thing I'll say is that, we only know that services are safe when Indigenous people tell us that they're safe. And one thing that we've experienced in our work is that often Indigenous leaders and people will come to our meetings, like our project meetings, and they'll call it a circle. And to me, that's just such a high honor to be expressed that, this feels like a circle, or, I'm really happy to be in the circle today, and here's what I'd like to talk about. So it's just really something that we hold up in this work and hold our hands up to Indigenous leaders and women in this field. So the layered and complex initiatives that we've been working on over time are in education mainly, and I'm going to focus on 2 of them, I think, that are of great interest. So Safe Care, it's our online blended course that we have available on the Learning Hub, the PHSA Learning Hub, and it's really about that intersection between harm reduction, substance use, Indigenous cultural safety, and trauma and violence informed practice. And anyone can register for it, anyone can sign up for it. It's about 5 modules, and then the 6th module that's in development and planning, or the 6th approach, is really about bringing this training to life with facilitation and level. It's called Safe Care Level 2. So our hope is that we can get together and have clinician or educator dyads with a person with living experience to really hone in on this work. And this is driven by a learning campaign approach where we know that, it's like we go by the 70-20-10 model, really. So 10% is this formal learning event that you might take online or, wherever. or even in person. And then 20% of the learning comes with mentoring and performance supports and job aids and some of those things that help embed the learning. But 70% of the work will be that synchronous on-the-job learning, that experiential learning, and that's what we're really trying to drive at with all of these education and learning initiatives. So I would implore you to check out SafeCare and think about it. We have a little microsite now attached to BC Women, so please feel free to take a look at that. The other thing I'll talk about, which is so important, is Eat, Sleep, Console. So this is the non-pharmacological management of neonatal abstinence syndrome. So we know that infants in the first 72 hours of being born may experience some withdrawal. Not all infants, but many who have been exposed to substance use in pregnancy. And this training is about, how do we get to a place where mother-baby togetherness is the gold standard of this work? And how do we get to a place where the mother-baby diet is a first line of treatment? We don't transfer babies to the NICU. We don't transfer babies when they require medical management for neonatal abstinence syndrome. Instead, we say, here's mom and babe, you have 10 reinforcing strategies you can use in this work. I'm getting the signal. Oh. Okay, so our key metrics, this is driven by our community partnership with 20 community partners across the province. And what I'd like to impart here is that over 3 years, we've served over 13,000 mothers and babies through these 20 organizational partnerships. And about a quarter of them were new to receiving any kind of service. And these are outdated numbers, actually. I have them updated to the end of March. So the blueprint, now as we get to this, all of this work and this collective energy and this learning and education have really been harnessed into this blueprint that has 38 recommendations across the continuum of pregnant and parenting women's services in the perinatal substance use continuum of care. So it's 38 recommendations, they're foundational, they talk about clinical work, and they talk about cross-sectoral partnership work with MCFD, the Ministry for Children and Family Development and Child Welfare Services, and we talk about partnerships with housing, and we talk about primary care. So it's a descriptive document, not prescriptive. It has multiple points of entry for anyone to really go into it, whether you're a leader, operational planner, whether you're an Indigenous leader, whether you're a person with living experience, there's something in there for everyone. And it's really designed to give you multiple points of entry to say, there's something I want to do with my interdisciplinary team as an example. Let me go to chapter 6 and take a look at some of those recommendations, and let's see what we can implement. So it's very open and crafted for optimal use, and hopefully it's a useful framework, because I was really listening to Jason Leach, about useful frameworks, and I was like, oh boy, I hope this is one of them. And this is a visual on the blueprint. So when we say what looks different now, we see a whole continuum, a fulsome continuum of care. That's robust. We see Indigenous people and leaders reflected and birth work reflected throughout the journey. We see what child welfare services needs to be a part of. We see a little bit about housing here. We see the role of peers and people with lived experience as being central. So this is really our visual representation of the blueprint that we talk about a lot, and we're able to dive into more detail with more time. So the blueprint is really here to turn what we know about evidence and leading practice into action. And that is so important in this work. And we know that for us in the provincial program, the blueprint is honestly the scaffolding of everything that we're doing going forward. So whether we're doing anything in there, like, for example, we've started an addiction medicine consult service at BC Women's Hospital. That's a part of the blueprint in one of the chapters in terms of recommendations. We know our colleagues in the North are engaging in some work to develop videos and resources in Indigenous cultural safety. Those come forward in the blueprint recommendations. So it's just important to center that it will be the scaffolding for our work going forward and guide our strategy as a provincial program and guide our partners, we hope, in this important work. And I think I made it.
Thank you very much, Pamela. And we have about 5 minutes for some questions. So Donna here will go around and please discuss.
And I left some copies of the document just on the side here, if you'd like to, on the white table on the side of the room, the left side here.
Any questions?
Okay.
Thank you very much for your presentation. I'm just wondering how your work, your framework, fits into the provincial maternity services strategy.
It's a really, really good question.
Hello, thank you for your work. I just wanted to inquire as to how your framework fits into the maternity services strategy.
Absolutely. We very much view the maternity services strategy as a complementary piece of work that we have informed, actually, because our blueprint and our genesis story is before the maternity services strategy took place. So Perinatal Services BC, as a part of PHSA and BC Women's, we work closely together. Our approaches in terms of education and how we do this work are very foundational, and we've lended our support to Perinatal Services BC to provide some of this best evidence in this area, because some of these practices are not just substance use focused, they're all perinatal care. So we just acknowledge that there's a place and space for everyone to do this work, and in particular our work in Indigenous cultural safety has informed some of the work that Lucy Barney, who is now retired as of this month, was leading in bringing ceremony back to acute care services. So there's many places and spaces of intersection and complement for that. I think that's a great question. I appreciate it.
Any other questions? Thank you so much, Pamela,
Thank
for your
you.
leadership in this area.
Thank you.
And now we'll move on to our next rapid fire. This will be with Brenda Tan, and it's on increasing vaginal birth rate in nulliparous women with Singleton Vertex term pregnancies. Brenda, thank you.
Thank you. Good morning. I want to acknowledge that I live, work, and play on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nation, and I'm grateful. Thank you. Before I begin, I just actually want to ask if anyone knows the top indication for hospital admissions in Canada. You can just shout it out. Childbirth. Childbirth, correct. And what is the most frequently performed surgery in all of cesarean sections? Good morning, welcome. So I'm Brenda Tan, family physician from Richmond. I'm here to present my QI project on increasing VBR, that's vaginal birth rate, and I have no conflicts of interest to declare. Okay, so I'm from Richmond Hospital, and at Richmond we perform about 2,000 deliveries a year with an overall section rate of 29%. While we have one of the best section rates in all of BC, and we're on par with the Canadian average, we actually still fall short of the WHO recommendation of 10 to 15% of all births. So Richmond joined Lionsgate and St. Paul's Hospital under the umbrella of the Vaginal Birth Collaborative to try to increase the VBR in Vancouver Coastal Health. We aim to increase the VBR in nulliparous women, and we specifically targeted this population because achieving that first vaginal birth really sets the foundation for future vaginal birthing. To develop a driver diagram, we engaged stakeholders, patient advisors, and a multidisciplinary team. And we decided to focus our change idea on hospital admission. We knew from studies that nulliparous women admitted in early labor had more interventions, including C-sections and epidurals. Also, GC also recommends that we should admit patients in active labor. The challenge is, the question is, what is active labor? So now I'm going to ask the audience, please raise your hand if when you think active labor starts. So I'm going to list some numbers. If you think active labor starts at 1 centimeter, raise your hands. 2, 3, 4 centimeters, some hands there, 5, 6, all right. So it turns out you're all right. If you live in BC, PSBC says 3 centimeters is active labor. SOGC says 4, while the WHO says 5. I'm sorry. The Americans and British actually say it's 6 centimeters. So there's not a consensus, but there are a few small things we can agree on. We can agree that 0 to 3 is early and 6 to 10 is active. But what do we do with the 4 to 5 centimeter gray zone? Like if you're 4 to 5 centimeters, are you early or are you active? So our first PDSA focused on active labor admission. So in our current state, patients were admitted at 4 centimeter, easy, 4 in, 4 in. But for the test of change, we actually asked our nurses and providers to take a pause at the 4 to 5 centimeter mark. And in this gray zone, we're going to ask you to apply clinical judgment to determine labor status. So we're not going to have a reflex to admit, we're going to ask for clinical judgment. So team members were asked to consider factors beyond cervical dilatation. So how old's your patient? What's her BMI? How intense are her contractions, et cetera. And they ask active labor, admit, early labor discharge. But the big idea was that many patients between 4 to 5 centimeters can be sent home. But how do we send patients home and support them at home? Well, of course, patients need to meet discharge criteria. And while working with patient advisors, we were able to identify a significant gap in communication. In the current state, the onus was on the patient to call back when things changed. That left patients at home nervous. Are things changing? And really anxious to come back. But what we learned was that patients needed more and wanted more. And so our second PDSA focused on active communication. So patients were instructed to actually call back at a very specific scheduled time. And in addition to that, our nurses provided many courtesy calls to check in on patients at home. And this created additional opportunities for assessment, for support, for encouragement, for education. But more importantly, patients felt connected to the birth center and not at home alone. For our last PDSA, we needed to align our patient expectations with our change idea. So for our third PDSA, we focused on education, active labor education. So we're trying to message, we're going to admit you in active labor and not at 4 centimeters, and we tried to deliver this message through different channels. So here's our data. So this run chart looks at our main outcome measure, vaginal birth rate. During the project, we tested our PDSA cycles on over 100 patients, and we achieved an overall vaginal birth rate of 89%, a 9% increase from baseline. Most impressive was our 94% active labor admission. So our vaginal birth rate was 94% for patients admitted in active labor. But to better understand our outcomes, we tried to segregate our patients based on Robson criteria. Robson 1, Nulliparous presenting in labor. The vaginal birth rate increased from 85 to 92%. For more process measures, truly exceptional is the group of patients in the middle. Robson 1 patients admitted in active labor without an epidural achieved a 98% vaginal birth rate. Like, this was incredible. We never expected it, that 47 out of 48 patients would have a vaginal birth. And when we looked at patients admitted in early versus active labor, both C-section rates and epidural rates tripled for Robson 1 patients admitted in early labor. Similar numbers for Robson 2 patients. When we look at process and balancing measures, we cross paths with that 4 to 5 centimeter dilemma 47 times. And we successfully discharged patients home 26 times. And we achieved all of this with no adverse maternal or neonatal outcomes, and in particular, no unplanned home births. Patients were happy. We surveyed 10 patients discharged home in that 4 to 5 centimeter gray zone. 90% reported being very satisfied or satisfied with their birth experience. Staff were even happier. 96% of staff reported being very satisfied or satisfied with our 2 main change ideas, which is active labor admission and active communication. Looking at a business case, we could potentially reduce the number of C-sections by 76 cases per year. Looking at Chi-High data, we could potentially save a lot of money, maybe $183,000, 107 hospital days. But the real impact is really the future impact for reduction of repeat cesarean sections. So here we are with promising results, and we might even be able to save the hospital a bit of money while increasing the vaginal birth rate. So time for implementation, just do it. I'm kind of hoping I'm out of time right now because I don't really want to share the next slide, but this is what happened. So here's our post-implementation run chart. The white is our pilot project vaginal birth rate, nicely trending all above the baseline. You can even appreciate the light green underneath, which is the birth center's numbers during the project. And then everyone's happy, happy, happy implementation. And then we just came crashing back down, right back to baseline. You can see that beautiful dark green line right back down. So what happened? Did people start caring after the data collection sheets disappeared from the front of the chart? Like there's no pressure? Did people stop caring after the chips and raffle prizes were gone? We didn't really know, but we appreciated that change is hard and we needed more help. So we got back to work. With FEM's support, we created a multidisciplinary team, and with the expertise of QI consultant, we reviewed our current state, performed gap analysis, developed new interventions, and aimed to increase the VBR by 3% by this fall. We developed an action plan that focused on leadership, care teams, patients, and communication, and we set goals for the next 30, 60, and 90 days. We just finished our first 60 days, and here are some action items at work. We have QI messaging at our nursing huddles. We developed a new staff-facing admissions pathway and patient-facing infographics. And you can appreciate that the chips are back. People are appreciating that. So now we'll just have to wait and see. What will our VBR be? But could this be the perfect trifecta? I was actually thinking about Dr. Ellen Giesbrecht's presentation from yesterday. She talked about the quadruple aim, but I was thinking about it as a trifecta. Like, could we have better patient outcomes in the setting of decreased workload, increased capacity, and decreased costs? What are the challenges? I think the challenge are patient expectations, QI leadership, and the culture at our birth center. Thank you.
Thank you very much, Brenda. And we have time for a couple of questions.
Brenda, thank you. That was an inspirational talk. I'm one of the anesthesiologists at BC Women's Hospital, where our problem is perhaps even slightly bigger than yours. And so this was a great example of how to promote a vaginal birth pathway for women who intend to have a vaginal birth. But I'm curious as to whether you have any suggestions for how we can reduce the cesarean rate overall, particularly in those patients who perhaps have no intention of even attempting vaginal birth and to address the kind of maternal choice C-section epidemic that seems to be taking off.
Mm-hmm. That's a great question. And we're very fortunate at Richmond to have a very low primary elective cesarean section rate. Our cesarean section on demand is actually very low, but that came with a lot of work and a lot of time. Richmond has a very large Asian population. It's not a secret that many patients are from China. And looking back 20, 30 years ago, number one thing was C-section on demand. And so over the years, I think through patient education, through birth experiences, through patients sharing that experiences with their friends and their families, there has been a shift to vaginal birth. And I think other communities may have different challenges, but I just having that lived experience and the sharing, I think that's really, really important. But at the same time, I think we still should support women's choice and give them good information to make good decisions. But we're very fortunate at Richmond. We have shifted. We have shifted. And actually, of our Robson 2 patients, zero were C-sections on demand. They were all inductions. Mhm. Thank you.
Hi, Brenda. Are you willing to speculate on what you think caused the rate to go back to the baseline? Like, was it culture? Was it providers? Was it patients?
Yeah, so that's that's been the big question on my mind. I think for Richmond, this QI project is really one of our first QI projects. And so I think a lot of people thought, oh, it's just the project. So we did it for the project. But then the project's done, and we just go back to whatever it is that we're doing. And so there wasn't the change culture. And there wasn't the change culture on all the different levels. And so originally, after I saw the numbers, I was just going to bury my head in the sand and disappear. And it was actually leadership that came back and brought us back to the table. It's like, hey, what happened? And we actually sat down as a department and asked ourselves, do we care about the vaginal birth rate? Like, is this a metric for the health authority? Is this a metric for the Ministry of Health? Or do we, as frontline workers, do we actually want to own this number? Do we care about this number? And so we had a bit of a rethink, because I was like, if people don't care, then, you know, the project is done. But actually, people at Richmond do care. And so it was just, I think it's a reminder, and it's just a reinvigoration, a recommitment, and just getting the team back up. So we'll see.
Yeah, thanks so much. I'm expecting my second child. I'm 37 weeks. I planned with my first child a planned home birth, to the dismay of my physician husband, who thought that that would be very dangerous. But I live in Victoria. The C-section rate there is very high. There's more women who are between 35 and 45 delivering. That leads to higher C-section rates. And your work is really inspirational, and I'm really grateful to see that QI project. I'm glad that you do care, because moms care, and I know your team sees people sort of during birth and maybe right after, but there's the whole 9 months right before that, that a lot of women do talk about online in their own community about how to prepare for birth, what things you need for your baby, all the latest gadgets, etc. And having gone through that and really believing that vaginal birth really sets you up for success, not only for the first kiddo, but for the next one, how can women who know about this work and who really feel strongly in support of that inspire other women in their community or in their mom circles, which are very powerful, to consider things like physical preparedness for birth, which is not often talked about, management of expectations and culture. You mentioned really important part of your triad. I think there's a misconception that birth is something that just happens to you, have very little control over how it goes, but we know that physical fitness, pain management expectations really lead to decreasing epidural rates, which then influence vaginal birth. So how can women support each other and talk about this in a respectful way, non-judgmental way, but also implement and encourage each other to prepare for birth the right way, so that when they walk through the door of your hospital, their expectations are a bit reset and they're more ready?
Mm-hmm. Wow, that's a big question. Labor preparedness and prenatal education is at the top of mind at Richmond Hospital. We're actually forming a website where patients can access information that is local, that is current, that is applicable. We have also reached out to doulas and prenatal educators who are, in contact with our patients to share this information. So we've shared with multiple prenatal educators, multiple doulas to spread the word. I've also done like 6 Zoom sessions with patients where it's a sharing time, sharing what we're doing, what we know, and also having patients share their experiences, what their hopes are, what their fears are, and how we can support each other. So there's definitely things that we are happy to share that has worked. I think the issue is having people like you with passion, and I think we need passionate people at the table, and I think passion spreads. Thank you.
Thank you very much, Brenda. And now for our final presentation, we have AJ Murray and Lana Sullivan presenting on improving the quality of care for patients experiencing perinatal loss at BC Women's Hospital. Thank you.
Good morning. Thank you for coming, and thank you to the BC Patient Safety and Quality Council for this opportunity. Today, we'll be sharing the work we have done in partnership with many stakeholders to develop resources to support patients who've experienced pregnancy and perinatal loss. This presentation will outline the processes involved, the products developed, and highlight the importance of engaging patients, bereaved parents, and clinicians when developing resources for the public on pregnancy and perinatal loss. My name is AJ Murray, and I'm a white settler of Polish and Irish ancestry.
My name is Lana Sullivan. I am a white settler of Scottish heritage. In the spirit of truth and reconciliation, we are humbled by the opportunity to meet with you in person on these unceded lands. For thousands of years, it's been the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh nations. 95% of British Columbia is on unceded traditional First Nations territory and home to many Indigenous peoples. We acknowledge with gratitude the opportunity to live, work, meet, and learn on their territories. The experience of pregnancy and perinatal loss is often traumatic. Support is essential to assist patients and bereaved parents as they navigate their grief process. The goal of our work is to fill the gaps, to provide support for people in BC who experience reproductive loss. For the purposes of our work, we use Canadian definitions of pregnancy loss and perinatal loss. Very simply, pregnancy loss includes miscarriage and recurrent pregnancy loss, both losses that occur before 20 weeks gestation. Perinatal loss occurs after 20 weeks gestation. We include stillbirth, including medical terminations, newborn and postneonatal losses in our definition of perinatal loss. The reality is, not every pregnancy comes to term, and not every birth results in a live baby. Pregnancy loss is more frequent in Canada. Miscarriage affects 25% of Canadian women. Perinatal loss is rare. Fewer than 1% of babies are stillborn in Canada. Although science has reduced the rate of demise in both pregnancies and the perinatal period, loss will continue to occur and affects Canadians every year. Our resources are intended to support those who experience all forms of loss. So what have we learned? Reproductive loss occurs in the context of uncertainty, stigma and silence, and changed identity. Let's unpack what these 3 things mean. As the pie charts illuminate, we only know so much about why miscarriage and stillbirth happen. There are elements of both that are not preventable or treatable. Healthcare providers have taught us that this requires humility and patience, as they are not able to provide answers to all of their patients' questions. For patients and bereaved parents, medical uncertainty causes some to research obsessively, self-blame, feel helpless, and develop heightened anxiety when considering subsequent pregnancy. We have learned that people who experience reproductive loss face stigma and silence. As a recurrent pregnancy loss participant says, this leads to our exacerbated trauma. Where are the resources that told me what to expect? Figuring everything out myself without any help or resources makes the experience that much more isolating and traumatic. Another recurrent pregnancy loss participant explains, this trauma downloads the burden of responsibility of support onto themselves. The isolation of loss is severe. You must be resourceful and self-advocate. This is incredibly difficult when resources are hard to find and you are in the midst of shock and emotional trauma. People who experience reproductive loss face social uncertainty and a change in their identity. One's status and identity is unstable and jeopardized, especially if prior to their loss, they identify as a parent with or without living children. We heard many stories of people who were pregnant but went home without a baby, feeling questioned about their identity as a parent. The ambiguity between parenthood and identity is wrapped up in their grief and loss experience. As one participant from the Hummingbird Project explains, it changes you forever. It changes your experience as a parent, as a spouse, as a friend. You see life through a different lens entirely. So you figure out a way to keep going because you have to somehow. But yeah, life is touched in a way that it's before and after. It's a very definitive marker, right? Like any significant event in life, it changes you.
Since 2019, we have partnered with clinicians, patients, and bereaved families to update and develop web pages, print materials, videos, and fact sheets to provide information and improve care for those experiencing pregnancy and perinatal loss. This list represents the resources developed to date, but our work in the area of perinatal loss is ongoing, with plans to develop further resources over the next few years. The response so far from clinicians and from those experiencing loss confirm that these resources address a critical gap in information and validate patients' and families' experiences. Developed initially for BC Women's patients and staff, these resources are now beginning to be used across BC. The importance of collaboration cannot be overstated. It was absolutely critical to the making of these resources. It was clinicians working in various departments at BC Women's who recognized the need for compassionate, plain language, and patient-facing resources on pregnancy and perinatal loss, and who provided content expertise and guidance at every stage of the work. It was the patients of the early pregnancy assessment and recurrent pregnancy loss clinics, the bereaved parent co-investigators of the Hummingbird Project, and the Butterfly Run Vancouver organizers and participants who shared their lived experiences of loss and provided critical direction and feedback on the draft resources. None of the resources created would have been possible without the participation of each of these groups. It's a challenge to summarize engagement, as our different projects require different types of participation. Using the International Association for Public Participation model you see here, we can say our engagement varied from consultation to full collaboration, and in one instance at least, empowerment. In addition to our main collaborators, we engaged 34 healthcare providers and clinicians from BC Women's and PHSA and 139 patients and/or bereaved parents across several projects. Participation varied from consultation, such as giving feedback on draft scripts and videos, to full collaboration as co-investigators in the case of the bereaved parents in the Hummingbird Project. Methods of engagement included focus groups, telephone interviews, surveys, and in the case of healthcare providers, we also invited their email feedback. As these projects spanned the 2 years of the pandemic, we were unable to meet in person, so focus groups and interviews were conducted by Zoom or by telephone. So an iterative process is the practice of building, refining, or improving a project, a product, or an initiative based on feedback or new information. And then the project improves over time as the result of revisions that are made due to the new information. So our process of resource development is iterative, and by that I mean we involved partners, patients, and bereaved parents, not just once, but repeatedly throughout the process. We incorporated their feedback, revised the draft materials, and then repeated the engagement process again and again throughout the development phases. To illustrate the iterative process, let's look at the development of the 2 videos on miscarriage and recurrent pregnancy loss. What is miscarriage? The first animated video in the series, completed in the fall of 2020, addresses some of the most frequently asked questions of patients in the early pregnancy assessment clinic. The second video in the series, entitled Recurrent Pregnancy Loss, Causes and Testing, has just been completed and will be launched this summer. The development of these videos is a good example of the iterative process. Each video script had 3 or more review cycles involving patients, clinicians, and community members with lived experience of miscarriage or recurrent pregnancy loss. During script development, the feedback from people with lived experience was so extensive, indicating that we were headed in the wrong direction, that we were actually inspired to completely change the plan for the videos and break up the subject matter into several topics for future work. The recurrent pregnancy loss script alone was rewritten completely at least 3 times in response to their insightful feedback, resulting not only in a greatly improved resource, but a more compassionate one. In addition to the 2 videos, we also developed a booklet on caring for yourself after the loss of a baby, web pages on bcwomens.ca, and digital and print handouts on various topics related to pregnancy and perinatal loss. These are just a few examples of some of the work. The Caring for Yourself After the Loss of Your Baby booklet is given to bereaved parents leaving BC Women's Hospital after having a stillbirth or after the death of their newborn. This booklet provides information on what to expect physically and emotionally in the immediate stages of grief, how to care for oneself in the days and weeks that follow, and with links to resources and support in the community. It's an example of the importance of building compassionate tools to address the isolation and stigma of loss that people experience, as well as providing key information at a crucial time. We're privileged to be part of the Hummingbird Project, a community-based research team of clinicians, researchers, and bereaved parents working towards developing a podcast series to support families experiencing stillbirth. We're currently analyzing data from focus groups and interviews and hope to begin developing podcast scripts in the fall of 2022. Early findings indicate a diverse range of possible podcast topics. The goal of these podcasts will be to give voice to the experience of individuals and families living through the shock and trauma of stillbirth, to help them rediscover their identity as parents within a supportive community of people with lived experience. Referring back to the participation model we showed you earlier, the Hummingbird Project aims not only to collaborate with bereaved parents, but to empower them to participate as decision makers at every stage of the development of the podcast series, from preparation to production to hosting.
Through our consultations with clinician partners and engagement with patients and bereaved parents, we've learned a tremendous amount on what to do, what not to do, what to say, what not to say. A bereaved parent from the Hummingbird Project explains change in identity is typical after the loss of a baby. It's completely okay to continue to mourn the loss of your baby because you're not only mourning the loss of your baby, but you're mourning the loss of all the hopes and dreams that you had for that baby. And you're mourning the relationships you've lost because people in your life weren't able to stand by you in your grief. Some patient and parent partners work with us to make a difference. They are determined to ensure all patients and bereaved parents are treated respectfully and appropriately. A recurrent pregnancy loss participant says, "The experience is so isolating. I'm trying to reach out to help others. If there's anything I can do, I want to be helpful. When we went through it, no one understood. I am still dealing with the trauma and how it will affect me the rest of my life." Patients and bereaved parents have taught us that language matters and insist that we use inclusive and healing words that do not minimize their identities or experiences. Producing resources in multiple formats also helps ensure accessing resources and support is the easy part in the grief journey parents and bereaved parents must endure. While we are proud of what we have done, our work is far from complete. We have a responsibility to do much more. We still hear stories of people feeling inadequately supported in their immediate phases of grief. We must continue to strengthen the in-hospital support we provide patients leading up to and immediately following their loss. We will do this by providing compassionate care that respects the patient experience and supports the choice of bereaved parents. This work is changing the way clinicians and departments at BC Women's act with the bereaved. BC Women's Hospital has a provincial mandate. All of our resources should cater to, at minimum, a provincial audience. We must continue to network with community organizations throughout BC to learn where bereaved parents and patients can get support closer to home. We will avoid words that stigmatize patients and bereaved parents like normal and common. And as anyone involved in quality improvement work understands, this means we must engage patients and bereaved parents early so that the resources we produce together resonate with their lived experience of pregnancy and perinatal loss. And so we forge ahead, listening, learning. The need for support and resources is so great. There are limitations to what hospitals can do to help. Lost parents in particular need to be treated with empathy and compassion so they can trust their healthcare professionals the next time they are patients. So we will remain grateful recipients for being allowed to listen, to observe, and to come to understand. While this process can seem messy, longer timelines, greater expense, iterative process repeating until the final product resonates with all stakeholders, the outcome is better for all. Thank you.
Thank you very much, AJ and Lana, for that inspiring work. We have time for some questions. Yes.
Thank you for that. It was very interesting and humbling to hear. I was very curious about that support piece. I'm just wondering if there's, if you guys are looking into the cultural aspects of that support, resource support piece for different groups.
Yeah, so yes is the answer to your question. We've been working with Indigenous health at Women's, and there's a challenge between some of the resources that we've provided and some of the resources that they feel are best to support the needs of Indigenous peoples in BC. There's lots of different elements that we've included in our resources that just don't fit what they feel Indigenous peoples need. And including, if you remember some of the visuals that we gave you, our resources are quite text heavy. And some of the visuals that we've used aren't necessarily appropriate. The colors are not necessarily the ones that that would be the best for Indigenous populations. So the challenge, of course, is that on our team, with our department, we don't have somebody that is from Indigenous health. So we need to work in partnership with Indigenous health, but they need to lead the work developing resources for Indigenous populations. And we need to bring our resources together as we develop them. In terms of some of the other groups, do you want to talk about the translation that you did? It's a little bit different than cultural sensitivity, but talking about inclusion of different people.
Well, I was just going to say the miscarriage video was translated into 4 different languages, French, Punjabi, Mandarin, and Cantonese. And we hope to do that as well for the second video, although it will require additional funding. But I think that your question was broader than that, and I think that is a challenge that we need to work on. We were, this was a variety of projects, so this is a umbrella presentation about multiple projects that were done over 4 years, over 2 years, sorry. So each project sort of has different funding, different mandate, although they were all on either pregnancy or perinatal loss. So we, I think that is work that we have to do, and that one of the things that is a challenge that we have to address going forward is how do our resources support everybody, and what are the accessibility issues, and what are the diversity issues, and I think that is work to still be done. I think one of the humbling things, right, about doing this work, but also attending the presentations at Quality Forum, is you see what other people are doing, and I'm really inspired that we need to do more. You know, like, we did some stuff, but we need to do a lot more to provide care for everybody and support.
The only other thing that I wanted to add is that different cultures in particularly different parts of the world receive and understand loss in very different ways. And I think that sometimes in terms of their loss experience in Canada contributes to the stigma and silence around it, because many cultures believe that if you have a baby that's died, particularly in later stages of pregnancy, that really it's not something that you should acknowledge or talk about. And there's a tension between the way that Canadian culture manages and deals with the process of the immediate phases of grief and loss versus some of the other cultures. And that's something that I think that we're learning to understand by talking with a variety of different groups and people, but there's lots more work there to be done.
Any other questions? Well, thank you very much, AJ and Lana, and thank you to all our presentations today. And I'm about to hand hand out some evaluation forms, so on your way out, I'll hand these out and please complete them. But yeah, I hope you enjoyed the rest of your day. Thank you.